Good afternoon, everyone, and welcome to the Nottinghamshire Health and Wellbeing Board at its first meeting of the municipal year. If I could draw the board's attention to item 1 of the agenda, which is the appointment of the chair, and to note the appointment by full council on the 11th of May 2023 of Councillor John Doddy as chair of the board for this municipal year. But Councillor Doddy unusually is unable to join us today. So the board at this meeting finds itself currently without a chair or a vice chair present. So the easiest way of resolving the current situation would seem to be to take the election of vice chair, currently item 5 on the agenda as part of agenda item 1. Members might remember that the previous vice chair was Dr. Jeremy Griffiths, but this time last year, this was just ahead. He was a member of the then clinical commissioning group, but this time last year we were just ahead of significant changes in the NHS structure, which then had knock-on impacts for the membership of the board. So at this time last year, a vice chair was not appointed, but that's all gone through. We've started a new municipal year. So yes, hopefully all members have had a chance to read that report of how the vice chair fits in. So as the first order of business, could I ask members of the board to nominate any candidates for the vice chair of the board for this year? Councillor Carlton.
Yes, thank you, Adrian. On behalf of the chair, I would like to propose Dylan Bartholomew for the position of vice chairman. This has been discussed with and is supported by Councillor Doddy and our Director of Public Health, Jonathan Gribben. Dylan has also kindly indicated that we'd be happy to take on the role if elected by members. So you've still got a chance to run away if you want to. Then I encourage you. There are many reasons for this nomination. Dylan has long-standing been an active member of this board since he joined in 2017, always bringing very useful contributions to our discussions on how to improve health and well-being. As a working general practitioner, he brings a clinical and health lens to our work, and if elected in the role of vice chair, he can advocate and input on the perspective of place on how to secure the best health outcomes for our residents in our county, as he is also the clinical lead for the Mid-Nottinghamshire Place-Based Partnership. I would therefore like to put forward the recommendation that Dylan is elected as a vice chair of the Nottinghamshire Health and Wellbeing Board for the year 23-24. Thank you.
Thank you, Councillor Carlton. Could I have anyone to second Dr. Bartholomew? I can see seconding from Victoria McGregor-Riley. Thank you very much. Do I have any further nominations from board members for the vice chair of the board? No, I see no further nominations, in which case, as the sole nominated candidate, Dr. Bartholomew is deemed elected as the vice chair. Dr. Bartholomew, could I invite you to chair this meeting of the Health and Wellbeing Board? Thank you.
First of all, thank you very much, and thank you very much, Councillor Carlton, for the introduction. So I hope I can stand to the expectations which have been raised here. And again, thank you very much for everyone in the board for appointing me. So hopefully John's having a good vacation, and Jeremy Griffiths before me is a big shoes to fill. So hopefully if I can live up to his expectations and standards, I think I would have done a good job as a vice chair. Let's move on to the meeting then. So first and foremost, apologies for absence.
Thank you, Chair. So I have apologies from Councillor Doddy, and I have apologies from Sharon Cadell from the Office of the Police and Crime Commissioner, from the Director of Public Health, Jonathan Gribbin, who is substituted for today by his deputy, Viv Robbins, from Melanie Williams, who is substituted today by Sue Batty, and from Fiona Callaghan, and in general, apologies from District and Borough Council members. As board members might be aware, the District and Borough Councils are following the May elections, largely sorting out their administrations, which means that some people either yet haven't been appointed or potentially appointed yesterday evening, and so aren't able to join us today. Thank you, Jeff.
Thank you, Adrian. So next we move on to declarations of interest by members and officers. Do any members or officers present have any disclosure of pecuniary interest or private interest, both pecuniary or non-pecuniary, to declare? No. Thank you. So next we move on to agenda item number 4, the minutes of the last meeting, which was held on Wednesday, the 8th March. I won't go through page by page, so just would like to ask from the board, do everyone agree the minutes as an accurate record of the last meeting, which was held on 8th of March? Thank you. The minutes can be approved as an accurate record. Thank you. Moving on to membership, then we've gone through the election of the vice chair. The next item is on the board's membership, and in terms of it's to consider the inclusion of a representative from Nottinghamshire Voluntary Community and Voluntary Sector as a permanent member of the board. Bryony, would you like to present? Thank you. Yes, sorry. So as the election has, I'm still learning my ropes, as you can see. As the election of the vice chair has been resolved and I'm sat here now, the board is now asked to know the election of the vice chair of the board for 23-24 municipal year. The current membership of the board as set out in section 4 of the report, the board's terms of reference as in appendix 1 of the report, and appointment of the chair of the Nottinghamshire Voluntary Community and Social Enterprise Alliance as a permanent member of the board. So I formally move the recommendations which are on page 13 of the agenda. And is that seconded, please? Thank you.
Second, as Chairman.
So, yes, Councillor Wilmot.
I could come in before you actually make the decision. We all know it is absolutely essential that we try to improve the health and well-being of our communities, and a representative of the Nottinghamshire Voluntary Community and Social Enterprise Allowance should have been an automatic selection to this board, actually. How else are we going to get the views of the community without having their representation on this board? And I'm sure many of you will be looking forward to hearing the views and experiences and some of these very important issues that we're discussing. I know that this alliance is a collective group. I've seen them meeting, that involves many local organisations, many local organisations, and it will play a vital role in giving vital information on the health and well-being of the community. So I welcome this decision now, but it really ought to have been done some time ago. Thank you very much, Chair.
Thank you very much, Councillor Wilmot. I fully agree and endorse your views on that. I think CVS has collectively play a significant role across the system. So it's been a gap in the membership of Health and Wellbeing Board. So very much recommend that. Thank you. Can I bring Sarah Thompson? No. Thank you. So next we move on to item number 6, the report sponsor. Oh, sorry. Yep, so Brian.
Thanks, Chair. So just to add a bit of context, the reason we've put forward the proposal to appoint the chair of the Community and Voluntary and Social Enterprise Alliance was actually requested by a member of board at a previous meeting as a way we could strengthen both our membership but also support greater partnership working on securing better outcomes for our residents. So I'm very pleased that I was able to propose that action on behalf of all the board members here present. And just to ascertain, it's not a mandatory membership. Some of our members here present are sort of obliged to attend because of the Health and Social Care Act. This is actually something that the board as a collective can request as a sort of optionary way of strengthening the work that we do on health and wellbeing.
Okay. And can I ask for a vote on the membership? Thank you.
Might appear to be unanimous support, Chair.
Thank you. So next we move on to the Better Care Fund governance arrangements for delegated approval. So few of or the majority of the members here in the board would have been part in a workshop which was last month, and so and the background of the BCF was launched in 2015 to establish pool budgets between NHS and local authorities, aiming to reduce the barriers often created by separate funding streams. So locally, the program joins up health and care services that manage their own health and well-being and live independently in the communities as long as possible. So Nottingham City Health and Wellbeing Board and the County Health and Wellbeing Board have the statutory oversight of the Better Care Fund. And currently in the county, the board signs off the BCF submissions as required in the national planning process. And to be clear, this will continue to be the case. So the process of the board's governance is outlined in paragraph 9 of the report, and this report seeks to establish arrangements for delegated approval in the urgent and unavoidable circumstances where the board cannot sign off a submission due to time scales or deadlines, or to delay a decision would pose a risk to the delivery of services for our residents. So for these particular circumstances, the report asks the board to approve the proposed delegated approval arrangements for the chair of Nottinghamshire Health and Wellbeing Board, Nottinghamshire County Council's Corporate Director of Adult Social Care and Public Health, and Chief Executive of the Nottingham and Nottinghamshire ICB to take decisions related to BCF. I formally move the recommendations which are on page 20 of the agenda pack. Is that seconded, please? Thank you, Councillor Carlton. So okay. Thanks. Yes.
If I could just add a point of clarification into the report, if I may. So it's just to confirm that obviously we have got the delegated approval within this route, but we do absolutely acknowledge that this doesn't change any delegated approvals that the individual stated within the document have within their own organisation. So we're not doing anything that means that anybody's delegating or approving anything that they wouldn't normally be able to delegate within their legal requirements and financial delegation within their organisation. So I just wanted to make that clear, and maybe that's something that we can just make sure is clear in the minutes, if that's okay.
Thank you very much.
Thank you.
Councillor Wilmot.
Thank you, Chair. I must say that I'm no lover of delegated decisions. They stifle debate and can contribute to hasty decision making. Many are made in a hurry without discussing the possible problems that this can cause. However, reading through the report, it seems that all possible problems in that area have been addressed. I realise that urgent decisions in this area have to be made so that people can live independently in their communities. I also welcome the idea of having a joint city and county oversight group, which will meet quarterly to review their performance levels. I know you will make sure that we receive information from these meetings. The delegated governance arrangements, including the set of principles, seem a measured response to the problem you are addressing, and the representatives suggest representatives that you put forward seem to be about right. So I'm happy with the decision. Thank you.
Thank you very much, Councillor Wilmot. Any further comments? Councillor Carlton.
Thank you, Chair. The only one I was going to point out, it's not necessarily an issue with the report as such. I think it was something that was coming up in the workshop, and obviously we've alluded to it in the opening part of this meeting. There's going to be quite a lot of new colleagues on this board, so I just think it'd be mindful that at some point that they're grounded in the detail of this and that sort of have that substance behind it. That's all.
Thank you very much, Councillor Carlton. So we'll take that as a note. So when the new members do come in, so it will be a bit of a process of doing all that. Sorry, silence. What we would probably want to do is just as a briefing pack and do an introduction in terms of the delegated authority and the decision making process. So thank you. With that, can I invite Sarah Fleming, the Program Director for System Development from the Nottinghamshire ICB, to present the paper, please? Thank you.
So there's probably not much more to add on this particular paper, really, and it was just to confirm those delegated arrangements were discussed previously at the workshop, and for the next item it'll be passing over to Sue Batty.
Take a vote on this. Can I take a vote on this? So good, unanimous approval. No. Can I just ask if anybody's not in favour of the delegated authority? No, thank you. So moving on to agenda item number 7, use of the Nottinghamshire County National Discharge Grant 2023-2024. The report sponsored by Melanie Williams and Sue Batty on her behalf.
Thank you, Chair. So the government's full year commitment to discharge grant is very welcome, and there's also the intention that it will continue for a second year. This enables us to do more sustainable planning, because a lot of what we need to put in place does relate to workforce capacity and services that we need to be able to deliver our improvement ambitions and plans to embed the discharge to assess model of hospital discharge. Health and social care, and my colleagues Lisa and Sarah sat over there ready to help answer any questions towards the end. We've worked together to develop a joint plan for how best to spend the grant and ensure that it supports delivery of our existing plans, and these have been based on independent review as well as our National Discharge Assurance Plan. We have already seen positive improvements, initial improvements from the work we've done on those areas. For example, for social care, when we put the transfer of care hubs, which were multidisciplinary teams in the hospital in autumn, it started to between then and now it halved the time it was actually taking for us to support people home for the people that came through to social care. So the aim is to grow on and build on the work that we've got in hand. Clearly one of the key criteria is to support properly embedding the discharge to assess model. So I just wanted to briefly describe that. What it means is that instead of assessing someone's ongoing health and care needs while the person's in hospital, there's a person-centred multidisciplinary decision made instead as to what short-term support a person needs to go home initially. And that might be that they actually don't need any support, or they might need short-term reablement support in their own home to maximise their independence, or they might need a more intense programme of accommodation-based rehab. So people go home or into rehab, and then any assessment of their future health, care and support needs, that is done once the person's settled back at home, which is obviously a much better place to make those sorts of decisions, particularly because they can have a big impact on people's lives. So there's a focus with discharge to assess on principles of everybody returning home first wherever possible, and making sure that everybody has access to therapy, rehab and reablement to maintain their independence and maximise their health and confidence to remain at home after a stay in hospital. So again, this is very positive for people. It does, however, require additional work for some areas of the system. For example, for social care, we would have originally done a lot of our work just in the hospital, but now we're doing multiple interventions in the hospital, and then when they're at home and then following up. But it is all for positive outcomes. So some systems were already starting to move to the discharge to assess model prior to March 2020. And then when, as part of the government's pandemic response, it became a rapid requirement for all systems to move towards this. And therefore, a significant amount of our plan for use of the fund across health and social care is being used under that first criteria, which is to reduce delayed hospital discharges and support the principles of discharge to assess, to fill some of those gaps that new model has left us with. And we have been able to fill those partially by some of the short-term bits of money, but we haven't been able to really sustain the workforce in the areas that we need. For example, with just 3 months winter plan funding. So we are looking at investing in additional staffing capacity with the aim of reducing the time people are waiting at various points across the whole process, looking to increase the numbers of people who can be discharged at weekends, and also to look at our practice and culture so that we consistently embed multidisciplinary team, strength-based, therapy-led practice that really focuses on getting the best outcomes for the person. And the plan covers the capacity needed in both the acute hospitals and the specialist mental health hospitals. And there's also in the plan significant additional investment in community reablement, which is also known, the terminology is P1, Pathway 1, which is included in the plan to maintain that. So that's the first block of criteria. The second main criteria is about planning services in advance so that providers can make their plans and recruit to their workforce. And it is the intention to increase investment in the voluntary sector, and that will build on work completed using some of the winter plan funds. Not everyone needs personal care or health support to return home. Many people might just need that bit of help to settle in, get the shopping in, turn the heating on, make sure that they're okay. And the evaluation of some work we did over winter is underway. The aim is to use some of the funding to work further with the voluntary sector to scope what full potential could be so that they're in a position to recruit before winter. And there's also funding under this block for some work for Skills for Care to undertake a needs assessment plan for independent adult social care providers. And for social care, they do make up the majority of our workforce, so it's really important we support them to be able to recruit. The third criteria is about learning from the evaluation of the impact of previous schemes funded using the discharge fund, and the intent is to extend use of short-term mental health reablement beds, which has been successful over winter. We also know that we will always experience times of pressure where we will need to be able to flexibly stand up some extra capacity quickly. This doesn't just happen over winter, and so we've also allocated some funding to support this. For example, we can usually offer additional hours in the short term to our reablement staff to bring in some extra capacity. If we can't do that, then the fallback is always use of interim residential care beds. It's not a good outcome for people if they could have gone home. So the intent of this plan is over time to reduce the use of that if we can to zero. It was very positive to see the criteria around improving collaboration and information sharing across health and social care services. And both health and care are investing in capacity to support and accelerate this work to develop more integrated ways of working across social care, reablement and community health, to develop an integrated health and therapy training programme, and also to provide some additional joint posts to support the strategic commissioning capacity we need to reshape services. The ICS is also undertaking a procurement exercise to identify a strategic transformation partner to support rapid accelerator work to improve both hospital discharge work and strengthen community services so that we start to build on the work we've done to avoid hospital and residential care admissions, and it's proposed that one-off amount is funded from the grant, and we will have appropriate stretch timescales and measures and benefits set during the early part of that 30-week programme of work. So hopefully that's just taken an overview through. I'm happy to answer any questions with my colleagues.
Thank you very much, Sue. Councillor Wilmot.
Thank you, Chairman. In welcoming this discharge grant, it's a little bit like closing the door after the horse has bolted, unfortunately. The people have been shouting long enough that the discharge scheme in hospital hasn't worked for years. Many patients are having to wait endlessly for rehabilitation services to get their act together. And the criteria set for the grant. Firstly, where are the trained staff going to come from to build additional adult social care and community-based re-enablement capacity? This council, like any other council across the country, has a real problem with recruitment and retaining staff. So it has to be asked, has the service got the capacity, staff-wise, to support the principles of discharge to access when an assessment will be required for any further needs? once they are settled back at home? A very, very big question, actually. And of course, one of the issues is I do welcome the part of the criteria that takes account of the variation in levels of demand for each patient required, and to determine how to build the workforce capacity needed. So the question is again, though, where is the workforce coming from? It says in the report, extra workforce will be required. I hope the idea of improving collaboration and information sharing across the health and social care services will work. Instead of when I was part of the position a few years ago, different departments and organisations were just seemed to be guarding their own areas. I hope that can be stopped, in its tracks, and work collaboratively together for the good of the people, really. Looking at the plans for the use of the resources provided, again asks the question, where are the staff coming from to complete these projects? As the demand for mental care staff is on the increase, where are the trained mental health workers needed going to come from? As we all know at the present time, because of the situation of people not having the resources, family problems, and job opportunities being not being able to take up because of illness and so forth. Mental health is rising dramatically at the moment, and we do have to address that situation. But again, you're going to need the necessary staff. Where is it going to come from? Because you need trained people. You can't just get them off the streets. They need to be trained. Have we got the training in ready for anybody that wants to come and try and become a mental health worker? Very difficult position for anyone to try, if it's a first job especially. Can I say, extending the service for organisations such as the voluntary sector to visit people who may need a wellbeing check, and I see that it's proposed to extend the scheme to enable 600 people to be visited. Again, where are these trained personnel coming from to service this improved service? Is it a case of expecting residents to do their important jobs for free because we can't recruit? That's an issue that needs looking into. As I say, I do welcome the work done at Lombard Street on the mental health problems. They do some real tremendous work. But it's not enough. More and more people post-COVID are suffering from mental issues through the cost of living crisis and family problems. So extra accommodation will be required for these extra projects. Mr. Chairman, for far too long, the problems that we're trying to address have been neglected, whether we like it or not, and a lot of hard work will be required to improve. What is my view? Well, my view that at the present time, it's a broken service, unfortunately, and but I see light at the end of the tunnel. I hope I do anyway, because it's a good paper, it's well worked out, but there are a lot of issues that need addressing, especially staff position. Thank you, Chairman.
Thank you very much, Councillor Beaumont. Is Councillor Tidswell, is that regarding the same question? Yes.
Thank you, Chair. Yes, as Councillor has just said, there's a lot of problematics that I cannot see them actually this resulting in getting rid of the problematics. We know the bed shortages. It always has been now for many, many years. I can go back, say, when I was a nurse, we used to make care plans around patients. Unfortunately, nowadays, what you do is the patient has to move around the options that the health service and the helpers are offering. It becomes more disjointed because we've had this section being privatised, that section being privatised, another section being privatised, so it becomes even more disjointed. And there is no way of smoothing that disjointment. A patient should have, as I believe, a care wrapped around them. That's what it used to be. But now the patients are having to move around to whatever is being offered until we actually get back to a system that is fully jointed and not, oh, so and so can offer you this, so and so can offer you that, and then you move around it. I'm still not going to be impressed until the day we actually have a health service that works for the patient, not for the because we used to believe in medical excellence first and then financial excellence second, but unfortunately it has got well wrapped around the wrong way. We still don't know how many beds are going to be available respite care. We still don't, as Justin pointed out, we still don't know how many staff are going to be available and we can afford. So I hope one day they will get their act together and it can be for the patient. And the other problem is diagnostics has come on at such a speed when the health service has been falling underneath, and that is also exacerbated. And it is frustrating for the staff that work in the system as well. Thank you, Chair.
Thank you very much. So, in terms of those two areas, I'll bring in a minute regarding both the workforce and then in terms of disjointed care. So I can see both Helen and Victoria McGregor have in terms of place-based partnership. But before that, can I just invite someone to prayer regarding the questions raised by First Constable Mob regarding workforce? Sorry, Sue.
Thank you, Chair. I think it's an excellent question. It's an extremely challenging area. What I can assure you is we haven't just gone into this plan thinking we'll just do the same as we always do. So we're looking at different ways of addressing some of the workforce issues. We don't actually have a problem in all our services. So our social care reablement service recruits well. It's back at turnover levels that we had pre-COVID. We can usually manage to recruit unqualified, unregistered community care officers who can be supported by qualified workers. So there are posts that we are managing to recruit to. Things are looking more positive, and also in the independent sector, home care providers are finding that as well. Although it does vary in different parts of the county, I must put that caveat. So also the fact that it's longer term funding significantly helps. The winter plan funding was 3 months. Not many people who are interested in jobs for that amount of time, and by the time you've recruited them, people can leave. However, having said that, we already have some of these posts in place. We already have some of the capacity, for example, in the voluntary sector in place, and hence one of the criteria is to extend what we already have. So we do have that. We also, in thinking it through, we haven't just put all the posts into one sector, so we've spread them across healthcare, independent sector, voluntary sector, I think, which increases our opportunities. They are attractive and relevant then to different people who might come forward to apply for those. We have also trialled a lot of new ways of recruitment over the past year. So we've been doing local recruitment campaigns, slimming down our council application process and various other things, and value-based recruitment where we just start finding out what people's values and attitudes are before we go on to anything more technical. All of those have seen an improvement. So we've now got a strategy, we've already got a strategy ready to recruit to these posts that will learn from all that and hopefully see some improvement. And very good point made, I think, about practice as well and our culture. So I did reference that within that there are some posts, there is some capacity to do training, both around our culture being person-centred, strength-based, how we work more collaboratively, and there is some training, for example, to deliver an integrated therapy training service. And we are looking at, occupational therapists are quite hard to find qualified ones, but we're looking at a model where we have those mentoring and supporting unqualified workers so that we increase our capacity. And there was a comment about our disjointed, fragmented services, and I think we've acknowledged that, and hence there's quite an investment under the areas of collaboration and joining services up. I think certainly, during COVID, when we were doing the best we could in very difficult circumstances, my social workers all had to leave hospital at that point. So some of the good, better joined up things, that was a government requirement. So and you could understand why, given infection control measures. But that some of the things that we had that were more joined up, I think we did lose a little bit, and we're very keen to bring those back. And that's a fundamental part of how we intend to use the money.
Thank you very much, Sue. So I'll come back to that in a minute, but I've got Helen next. Helen Smith from South BBP.
Thank you, Tim, and thanks, Sue. Just a couple of bits to pull out, and I think you've covered part of it in the second part of your answer. When the 3-month hospital discharge fund came to this meeting before, we very much talked about outcomes for people. I'm still not feeling the outcomes of people being in the right place. We talk about beds being made available and people being discharged, but it'd be really great to hear how this impacts on people getting to the right place with the right level of support. The bit around the cultural piece is the massive bit for me, and there's a reference to strengths-based working, and you talked about personalised care, but having that higher up, I think, would really raise the profile of that, because we have had discharge to assess and procedures and processes, as Councillor Tidesall said, to move people through, but actually flipping it to look at actually for the person themselves, what do they need and how can the system support them, would be great. So to hear in all of those schemes a very strong element of strengths-based personalised care would be really reassuring, and making sure that those skills described in that last bit are about that, as well as those physical skills, because unless we do that person-centred bit, even changing the process isn't going to change the outcome. Thanks.
Thank you very much, Helen. Can I bring in Victoria?
Thanks, Chair. I really welcome the paper, and it obviously shows a lot of thought and detail in terms of trying to move this agenda on, and it is a very challenging agenda, and I think we all recognise that. It was just some points really, obviously there's clear reference to collaborative approaches, and there's a bit of a plea that we do engage actively with our place-based partnerships around the future implementation and design as this goes into further maturity. Place-based partners know their communities really, really well, and can, I think, offer an awful lot in terms of understanding the opportunities around local voluntary and community sector organisation and engagement, and often we have really good, strong relationships with those colleagues as well. So I think place-based partnerships really do need to come to the fore of this in terms of supporting implementation. There's other opportunities around, for example, potentially shared training and development opportunities, making sure that we really do live and breathe the making every contact count initiative and philosophy of approach that we've committed to as part of our integrated care strategy. So, could we explore that a little bit further as well? And also, can we make sure that in the distribution and allocation of resources, we're thinking about really concepts of health inequalities and promoting health equity, so that we really are speaking our values as well, that again are outlined and enshrined in our health, in our integrated care strategy, and will be coming out as part of the joint forward plan that we'll be speaking about in a little later. So I think absolutely welcome this. I think we're doing some really good work to help our population, but I think place-based partnerships really do need to play a role in this as well.
Thank you very much, Victoria. Next, I'll bring in Sarah.
Thank you, Chair. Just to follow on from your comments, which I absolutely agree with. In terms of, we know the challenges of recruitment and how we're going to actually make the ability to reach these posts, but that integrated working, I think, absolutely needs, it's time that the voluntary and community sector were brought into that in terms of workforce development within the ICS structures. Place-based partnerships, absolutely very close to that sector. And I think one of the key things there is looking at not seeing with the old eyes, but looking at through the new lens of the integrated care system and who is the workforce. So I would like to see how workforce planning does integrate across all partners in the system. I've got a specific question of clarity. So in terms of Lombard Street, because it mentions just 9 people, is that the average of patients that come through with the particular needs that would need support at Lombard Street, or is that a typo? Because I just think 9's not very many people. So I just wanted some clarification on that. And the other thing, I guess, with all these initiatives, and you've had a year already of the grant fund, and this is a continuation, and the work that's done around winter pressures, it's really great. One of the things that we hear at Health Watch is the level of people being readmitted. So in terms of that, push to discharge, absolutely, which comes back to your point, Helen, around, are people in the right place at the right time? And are we monitoring in order to understand, are people in the right place at the right time, or are we failing some people in the rush to discharge? The other element, obviously, yes, social care and health. Social care particularly is the biggest element of this in terms of people in their own homes, but we also know the biggest blockage that we hear other than social care is pharmacy in the hospitals and getting people out with the medication, and that blocks more beds than I think people realise. So, again, it's that whole system integrated approach, not just everything on the door of social care. But I know I welcome this additional grant. I think it's really good, and I think the initiatives that are being put forward in this proposal are something that we really would recommend from Health Watch's perspective.
Thank you very much, Sarah. Can I bring you? Thank you.
Thank you, Chair. So I think some of my points have been covered by other people's comments, but really supportive of the approach and really supportive around some approaches around strengths-based approaches that link into personalisation care and picking up on some of the equity and prevention comments that have already been covered, so I won't cover those again. I suppose, Sue, what I'm really interested in is you talk about the transformation partner that you're going to have and this accelerator programme that you're looking at. So I was just wondering what opportunities there are for us to support you in a broader system approach around that, and thinking obviously from a public health point of view, how we can really genuinely embed some more approaches around prevention so that we don't get people being readmitted back into hospital if possible, and really thinking around that equity lens. So really it's just a bit of an offer that if you would like some support, then more than happy to help and support with that. Thank you.
Thank you very much. Any further comments? So get Councillor Wilmot first and then Councillor. Yes, thank you.
Yeah, just wanted to ask. You said you've got a training program for some of the items. Just wanted to know how long does it take to actually train the person before they can, from starting on the training scheme to the end, so that they are efficient in and what the work that they're going to do.
Sue or thank you.
Thank you, Chair. So I'll kick off, and then I think I'll bring in maybe Lisa a bit to speak maybe on a bit more about the detail about readmissions pharmacy, a bit about the acute work happening there. So absolutely, outcomes are at the heart of it in terms of, and I think hopefully in this report, the fact that we are really majoring a big piece of work we're doing is around the people who need to go into rehab accommodation and reablement, and we are working on a joint data set, working our way through that, and part of that work will include joined up data on our outcomes. And as we look into develop more integrated ways of working across social care, reablement, and community health, we'll have a joint outcomes framework, joint quality assurance. So those are in there. I suppose I'll just reflect that that's not what we're required to report on. Again, back to the Department of Health. So, but we will be doing that anyway. And strength-based approaches are completely high up on that, but also therapy-led, with the intent that there should be no long-term decision about a person's care and support unless they've had the opportunity for input from a therapist, because we know that can really promote their independence. So just some assurance there, I think, Helen. Yes, we can definitely, Victoria, we've got those networks, we can start to do that collaboration. There is already obviously a strong governance structure in place. There's an operational group that Lisa's integrated discharge list chairs. There's an ageing well board that feeds up into the ICB and local authorities. Lisa is a joint appointment. So there's lots of opportunities to engage in that work, and I'm sure we can pick that up, Victoria, in some of our conversations. And in terms of health inequalities and inequities, what we have seen, what we have done with the resources is not everywhere has needed the same additional resources. So I can give an example. In my social care teams that support the hospitals, we just didn't. The demand has increased at Sherwood Forest Hospital across Mansfield and Nashville much more than in the other areas. So as part of this plan, we've put more staffing into that area. However, things change over time, so that's flexible, and we will deploy either on a short term or on a longer term basis staff to where we need them to be. There was a comment about integrated working, which is totally at the heart of all of this. And as I mentioned before, building some of those things that we might have lost a little bit when we couldn't co-locate in a variety of places during COVID. Lombard Street is just one. It's just one at the moment, and that's initiated by social care. If there is need and we can joint fund, then that might be something we can extend in the future. And that's one of the reasons why we've got the Joint Mental Health Commissioner post to start to look at that set of services, and would it be better to invest more in that than in other services. Thank you for your offer. That will be very helpful. The transformation partner at the moment is still in procurement, so we've not got the announcement of who is the successful partner, and that will be a 30-week intensive piece of work. So we'll absolutely be looking for support from a number of places with that. Thanks for that. And how long does it take to train? I suppose it depends. It depends what you're training for. So. But the training that we've put in here is things that we can. It's not about qualified staff. We've got a number of things for qualified staff which can take a number of years, but these are modules that people can dip in and dip out of. So once it's built, the integrated therapy will have a number of aspects of training. Some people might only do a little bit of it, some people might do a lot of it. So it can skill people up, it will be able to skill some people up in a short time. Other people might go on, for a year or so to get fully skilled as they develop. But everybody comes with a different starting point. So it's a bit of it's not an answer I can give you a finite question to. I could give you a finite timeline. At the moment, if you're training to be an occupational therapist to be qualified, that's 4 years. If you're training to be a qualified social worker, that's 3 years. But what we're trying to do within this is train up non-registered staff so that they can work and be supported by the registered qualified staff. So we're giving them more of those staff the skills, if that makes sense. And then I'll hand over to Lisa just to talk a bit about readmissions are part of this and the work we're doing with our pharmacies.
Okay, so from a readmissions point of view, Sue's briefly touched on it already. We're pulling together a joint data set that's really looking at that system one version of the truth. So actually what Sue will see from a social care point of view, what NUH or Sherwood Forest or Bassett Law will see, what the community health providers will see is all the same information. So we all agree that's our one version of the truth for the system. And then within that, we're starting to look at readmissions and actually what that means. So if we're getting so many readmissions from a certain hospital or certain ward, we're trying to look at the deep diving. But I will say it's very, very early doors yet. This is only just starting. We've only started this piece of work around 3 or 4 months ago, but it is definitely an intention to start really drilling down on those readmissions and looking at that. And then from a pharmacy point of view, I think you're absolutely right. I can't remember who mentioned it, but yeah, it's a massive problem nationally. But we have started in all 3 of the acute trusts doing some bespoke piece of work around pre-planning discharges. So actually, what can we do 24, 48 hours before the person's medically safe to leave, so that we can really start getting those TTOs ready, getting the transport ready, getting that equipment ready. So for example, at NUH, we've started a pilot with a bit of a hit squad. So once somebody's going with a pathway 1 package, what we're doing is getting a hit squad to go out and make sure those things are done 24 hours before, so we can really stopping some of that waiting in hospital for any longer. But it's a big problem. We are trying to work on it, but I think it's ingrained cultures, like we've said, some of the things. So it's just really trying to chip away a little bit at a time, but it's definitely on our agenda from an integrated point of view for discharge.
Thank you very much, Lisa. And so, can we Sarah then come back to consultants? Well, is that okay?
Yeah, I might only quickly anyway.
Oh, then go on.
It's just a thought that occurred to me was the fact that how is CQC going to cope with all these? They must be struggling already. When you look at the vast amount of work they have to get the CQC Commission. Now, I just don't know how they manage to get so much work done. It's not just the along with the system. I find it frightening when I think how much work CQC is getting loads onto it, as well as the health service side, social services side, and everything. I do think, I always wonder whether we're asking too much of the CQC, to be honest with you.
Thank you. I don't know the answer, but what I'm aware from the CQC perspective is there's a review of how the inspection regime is going from a health perspective. I suspect it's the same across the care sector as well, very much taking into board what the challenges they're facing. So there is a big CQC review in how they inspect or do from a health perspective as care. So thank you very much for that. Can I bring Sarah in?
Thank you. It was just to say that clearly today we talked about the discharge element of the Better Care Fund, and there are other parts to it. And to Helen's point, really asking about the outcomes. For next time, Health and Wellbeing Board, we are going to bring the end of year report, which will bring some of those reflections together. So hopefully you'll get a bit of a better feel for how things have gone and actually how patients are experiencing some of those services. So we will commit to bringing that back. Probably recognise, as Lisa said, it's an ongoing process. So again, it'll be helpful for the board to shape some of the things you want to see. But I think we're trying to make this much more regular, interactive with you, so you get that real feel throughout the year of what we're doing and how things are developing. And again, to Victoria's point, that will really help us with the engagement, I think, with place-based partnerships as well.
Yes.
Sorry to have to come in again, but just one question quickly went straight to my head. You just said that training will be ongoing. Are you saying then that the person that is taking the training will also be doing the job at the same time? Because it concerns me that you're saying the training may go on for 12 months or so, and that the position might be that the work they're doing, they don't even know the answer or the way it should be done because of the taking such a great number of months to get all the training done. I just wondered if you got an answer for that one, please.
Sue.
Yes, so a lot of the roles that are in the plan don't require any formal training, and we do a lot of our training on the job, and people can take part in NVQs, and those are work-based opportunities. And yes, this is training that will support people through their work. So the strengths-based work that we're doing, we'll be doing that with teams. It will be just part of their work, working alongside them, and the developing the integrated therapy training piece of work that needs developing, so I can't give a lot more detail about that. So I can only really answer as opposed to these roles because it's a vast question about training for jobs, but the answer is a lot of the roles don't require any formal qualifications for people to come, so we can train them on the job. What we have found for those entry level roles is that values and attitudes are really, really key. We can teach people how to do the jobs, but it's very difficult if people haven't got the right sort of approach to this kind of work.
Thank you very much, Sue. So just to recap the number, thank you very much everyone for your questions, and Sue, Lisa, Sarah for answering the questions as well. So before I move on to the recommendation, I think we discussed about disjointed care and moving on to the integrated working, joint up data, workforce challenges, rightly so, training, the role of place, addressing health inequalities, and promoting equity. And the reason for that very short summary is I want the board to keep that in mind when we move to the second part, where we start looking at the joint forward plan, because most of these themes which we discussed will be highlighted in that discussion. So thank you very much for everyone's contribution. So now the board is asked to sign off the plan for the use of discharge fund 2023 to 24. I formally move the recommendations which are on page 32 of the agenda pack. Is that seconded, please? Thank you very much. Can I get a vote? All in favor? Thank you. So it's a majority, so we move the recommendation. Thank you very much. So next is of the work program. So the Health and Wellbeing Board's work program for 2023 is provided on pages 39 to 41 of the agenda pack. So the members are asked to note the work program and consideration to be given to any changes which the board wishes to make to this work program. So I formally move the recommendations which are on page 38 in the agenda pack. And is that seconded, please? Okay. And anyone want to make any comments or suggestions? Nope. So thank you very much. So that brings to end the formal meeting of the Health and Wellbeing Board now. So next we have a workshop, is that right? So before we do that, we can have a quick 5-minute break for a quick catch up of tea, coffee, or just stretch your legs. And thank you very much for bearing with me on my first day as chair in this session. So thank you once again. Thank you.